This talk is something that has sort of become more relevant to me and I've become more aware of as I've developed my veterinary career, and it really is looking at the head to the tail, the neck and the back. And I find, and most people probably agree, it really is the rudder and the drive shaft of the horse. So you have to look at it in the complete settings, and also it's very hard to assess because it's a very subjective assessment. So one horse's stiffness may be completely different to another horse's stiffness. So hopefully we will work through this and you guys can all hear me. So in this short talk, we'll try and go for about 50 minutes. I plan to sort of discuss the anatomy, how we examine the back, and then some of the common clinical issues, and then the examination of pre-purchase we'll try and touch on at the end, because the back and neck really do open a big can of worms when we come to pre-purchase. So we will have a look at that at the end. So the anatomy. We've got 7 cervical vertebrae, 18 thoracic, 6 lumbar, and then we have the sacrum and the pelvis, which I've included in this. They're all part of the back, and we really need to assess them all in their entirety when we look at it. So it's not just one little bit. We're looking at all different parts. So when we, let's go back. When we start here, if you can see here, we've got the 7 cervical. You go into your thoracic region, which we all sit upon, the lumbar region, which gives us their power, pelvis and the sacrum there, and that really helps. So what we plan to do from here is we'll then look at it in more detail. So we start with the neck region. So with the neck, the important thing to notice is the difference in the shape of the vertebra. You sort of really got 3 types of vertebra. C1, C2, 3, 4, 5, 6, 7. You know you're in the thoracic region when we get these dorsal spinous processes, but there can be variation in the anatomy and the shape of them. So here we're looking at C1. Very important. We tend to get injuries in this region when horses pull back. It's one of the more common issues to have. So then we head down in here. We've got 2 joints to be aware of. We've got this joint here, the main articulation, and then this other joint up here, which can be a little bit hard to image at times. This is C2 to C3. In this region here is where we tend to get arthritic changes, and we can sometimes get neck arthritis causing soreness. Back here, this is C6, C7. We start to lose detail when we are x-raying these because we've got the shoulders in the way, and we can't just quite get through as well. So we do lose a bit of detail there. So then we go into thoracolumbar region. We've got these dorsal spinous processes that we all start to worry about. You got 1, 2, 3, 4, 5, 6, and then we start running 7, 8, 9, 10, 11, 12, 13, 14. We've got 18 thoracic vertebrae. We've got 18 ribs. So they're also got articulations on here. So when we look at the vertebra of the thoracic region, these are the withers. Quite normal to have a cartilaginous part on the top. And so this is quite a normal appearance of a horse. Then when you head on, we start to head on back. They're very vertical to start with. And then as we move further down the back, they start to change and tip forward. It's quite a normal. We've got the ribs down the bottom here, and we're heading towards the back. So the thoracolumbar region, 6 lumbar vertebra, limited movement. You get some side-to-side movement, but not very much up and down movement. Most of your up and down is coming from your thoracic region, but it's a very important region. We get pain in this region. Muscular pain mostly, but we can get issues with these vertebrae as well. So your sacroiliac joint, we all know about SI joint pain, and it's a big problem. So, sorry, excuse the quality of the picture, but this image taken off the internet really shows the best way. We've got the pelvis sweeping up and then attaching on the sides here to the sacrum, okay? So this is the sacroiliac joint. It's not a true joint, but it's definitely a very important part that we need to worry about. So let's move on to the clinical pain. I don't think I doubt we've any questions from that there. So no, that's fine. Sorry, just trying to hide this. So when we're looking at the back pain and stuff like that there, the clinical history which you guys can give to us as vets is so important. Like, you've got to document everything. It's not just, oh, my horse is sore in its back. What's it doing? When's it doing? The different variations. So, you know, does it improve with a warm-up? Does it improve on a 2-point seat? Is the horse fine moving on without a saddle on? Is it lunging fine? But it's only when you see the rider on board that you start to see the problems. So when you are, for clients of the practice, and some of you are and some of you aren't, if you aren't, welcome. If you are, thank you very much. But telling us and understanding that allows us to schedule the proper amount of time for your examination if we've got a problem. So if it is more evident under certain ridden parts, then that's really important to know. So with the clinical history, we want to know when the problem's developed, what we're saying, what we're finding. Then we would generally do a physical exam. So with a physical exam of the back, sometimes the best way to start is stand back and have a look. You know, have you got the normal muscles? Does the horse look well muscled, or is it dropping off? You know, and we've seen those horses where you get behind the withers, you can really see the spinous processes and you've got not much muscle. Most of the time we've got loss of muscle because the horse isn't using it. So if you don't use it, you lose it, you know, and that's the big thing we keep hearing time and time again. And we see time and time again, if they're not using the muscles properly, they will lose them. They won't keep them, they will lose them. So the other thing I'd say is sometimes people call us out and say, oh, there's bumps along the back. It's actually, generally when we x-ray this horse, we don't find you've got new bone formation. You've just got loss of muscle. So it makes the back stand out a lot better. So your physical exam, we're then starting to look, is there pain on palpation? Is there any soreness, loss of muscle, as we talked about? And then we start to look at the dynamic exam. So with the dynamic, starting at the ears, you know, is there any resentment of putting a head collar on, putting a bridle on? Is the horse sore to palpate? There's a little bursa behind usually where the bridle sits on the top, that can sometimes become inflamed, and you can get a bursitis there. Equally, horses that have had injuries, young horses pulling back, they can get sensitivity and new bone growth there, and they can get sensitive on the top of their head. So then when we're palpating along the neck, both sides, left and right. So we say, is there pain on palpation of different joints as we move down the neck? And remember, we've got all those joints. We need to palpate them, no different in the legs. Then you get into your back region. So this is can be a little bit of a tricky one, because some horses are just generally sensitive, generally a chestnut gelding, if I'm going to be honest. They're very sensitive in their skin. So you go digging and palpating, you'll get a strong reaction. You've got to understand what's a normal reaction for that horse, what's an abnormal reaction. And then the dynamic exams that we talk about, lifting underneath from the sternum and asking the horse to lift up. It should comfortably do that. If you've got a horse with a sore back and you've got a vet out examining it, make sure you're holding the head properly, because that's when someone can get bitten. If you've got a really sore horse and you lift it, they can be really resentful. So once we've done that there, then we're moving into the lumbar region. Palpating along the back, is there any movement, side to side movement? So we might examine the horse. Sometimes we're trying to see the lateral movement. So holding the tail head, I'll start to rotate it and see if there's how much movement is there side to side. And then a good indication of sacroiliac tightness is a horse should be able to lift. So if you're standing near hind, the near hind should be able to be lifted and the toe pulled across so it can almost touch the fetlock on the other side. That's normal. That's a normal range. Then we start to look at the horse on the lunge, trotting up. How is it using itself? Does it want to reach down? Does it want to hold its head up? What's it do? And then we get you guys on board. But often if the horse is presented for rearing or bucking, I'm really uncomfortable putting you guys on board. I don't want to run the risk. So some of the histories we've had, I just went through some of horses that we sort of identified. There's so many issues here, and back pain often can be a diagnosis by exclusion rather than a definitive diagnosis. So it can be quite hard to nerve block a back. It's such a big area. Where do you start? So an unwillingness to reach. So dressage horses not wanting to go into the bridle, not want to do the reach down. They don't want to stretch and come up. Some of them just won't go forward. Recurring saddle issues, you know, throwing the rider side, rearing, bucking. An unknown lameness as well can cause it. The girthiness, the touchiness, loss of canter power, particularly with sacroiliac, or is starting to disunite behind quite commonly, can be sacroiliac dysfunction. You get into your show jumpers, the loss of the bascule, they don't want to stretch, and that's no different to a dressage horse wanting to reach down as you're asking it to stretch, and the hollowing of the back. So many of those symptoms, though, can be other conditions as well. You know, bucking, rearing, you know, gastric ulcers, so many things. So it is quite a difficult diagnosis to reach. So as we just went through the physical exam with the movement of the neck, the range of motion and stuff like that, quite an extreme example here of a horse very comfortable. We want to see how far they reach. Can they reach down? Can they reach the side? Can they bend left, bend right? Okay, so I think we've covered a lot of this already. So let's move on to the diagnostic imaging. This is an area that is quite a big area, and the different options we've got available. So we're going to cover basically 5 main areas that we're going to cover. So your X-ray, your ultrasound, your thermography, scintigraphy, and then MRI and CT I'm going to put in the same category. So your diagnostic imaging, we're going to start with X-ray. Really easy to do. It's really simple. It can be done usually at your stable. Most of our digital X-ray machines now can easily get through most horses. Some of the bigger warm bloods, we do struggle a little bit in the lumbar region. We just got so much muscle mass. It's really easy to do. You can do the back, you can do the neck. Simple, easy. But there is some downsides of it, and this is something I want to stress. It's not assessing whether something's an active change, it's only whether there is a change. And there are variations between normal horses. It's not a black and white thing. And then also your issue with your big horses trying to get through. How you get through that back region. Neck's okay, but getting in the back can be quite hard. Ultrasound, really simple to do. I love it. You can assess the joint surfaces. You can look for spurring in the joints, any muscle size changes. It's a dynamic assessment as well, and it's great for looking at pelvic fractures. Probably is my go-to. You know, if I can see something that I'm concerned about and I think you've got a pelvic fracture, we wouldn't even consider other options. We would do an ultrasound. It's so easy and it's great to track them. You're only seeing a small part, so there's some negativity on it. So this is a horse here with a pelvic fracture. The video's just started playing. So the thermography. What's the benefits of it? It's really easy. It's non-invasive. It's really simple. But you have to be careful with thermography. It's got poor sensitivity. It's very non-specific. And the other thing that needs to be really, I can't strongly, talk about enough is you have to control the environment the horse is in. So you've got to be aware that if a horse is standing in the stable and has had a rug on and someone's coming to do a thermography exam, if it's got one side towards the sun, the other side towards the dark, there will be differences in temperature. So you really need to try and get the horse into an environment where there's no cool breezes, where there's no sun, and give them a time to acclimatize. Now that can be up to 50 minutes. I did a study when I was a student a long time ago, and it takes about 45 minutes, and you have to be aware even of cross breezes. So a breeze blowing down the breezeway can actually affect what your thermography is going to do, because obviously you're only looking at skin temperature. But can be a useful tool to sometimes help you. Scintigraphy is probably our goal, our best modality to pick up back and neck problems. It really is. It's super sensitive to active changes. You can assess deeper structures. You're not going to be inhibited by a big warm blood. But yeah, it's absolutely fabulous, and really is sometimes the second follow-up treatment or follow-up diagnostic after maybe X-ray. If you're concerned that you might have some changes, but you're not sure of the significance on X-ray, then scintigraphy would be the next step to go. Really is very beneficial. Some cons on it. It's a hospital-based treatment, and it adds a little bit of cost to the diagnosis. So it does make a difference, but can give you a lot of very useful information and also help targeted treatment down the track. So I don't see any questions. I don't know if that's created any questions. We'll probably get into the conditions now, because that I think will be more useful. So I'm going to deal with 5 main conditions tonight, hopefully. We've got wobblers, cervical arthritis, kissing spines, pelvic fractures, and SI joint pain. I've kept it relatively simple. Hopefully we can answer most people's questions as we go. So what is wobblers? Basically, it's a cervical stenosis. So what are the symptoms we sometimes see? Generally presents in a younger horse, so anywhere from a yearling up to 3, 4, 5, 6, 7. It is a progressive condition generally, and the horses often are described as awkward. Some of them will fall over. They'll often have a lot of trouble backing up. They don't step back, they drag back. So when you move them backwards, they'll drag their feet, they won't step back. Clumsy. So tripping over things, catching things, they're horses that I'd be wary of. An equal will stand on themselves behind. So any horse that starts standing on it might be a bit strange. And they can be a little bit, if the forelimbs are affected, they're a little bit hypermetric. And by hypermetric, we mean high stepping. So that's something we see at times. So when we look for wobblers, we're often looking, really, it's a clinical exam that's really going to drive where you're going with it. You know, they'll struggle to back up. Tight circles, won't cross the hind legs. So you might have seen on vet check where we stand beside the horse at the girth and we ask the horse to walk forward into a tight circle. When they cross over their back legs, the inside back leg should cross over to the outside, and the outside one should come round and step down normally. Equally, the outside one shouldn't swing itself out, it should just step across normally. So any horse that won't step across is question mark, have an issue, and equally any horse that is throwing the leg out. But one thing to be careful of when you're doing those, when I'm doing the pre-purchase, some people just sort of grab the horse and try and spin it, and the horse pivots on the back legs. You've actually got to walk them into the circle. So get beside them, get them walking forward, and then walk them into the tight circle. That'll help you show, and most horses relax. They struggle to go downhill as well. That's the other thing that they really do. And they can be a bit funny that way. Canter can sometimes show it up more readily at times as well in the lower grades. They normally have a normal range of motion of their neck. They're not restricted, they move. But when you're backing them up or walking them, sometimes head position will make a difference. So you can lift them up, their head up, and they'll get a little bit slappy, and you drop it down, it's normal. Those are horses that have got a dynamic lesion. So there's a couple of different grading scales. The only reason when you'd need to worry about these grading scales is if you have a horse under insurance. Just a word of warning, if you do have a young horse and insured for this, that you can claim on that, you have to get the definition that the insurance company uses. Every insurance company uses a slightly different definition and grading scale, and you have to make sure you tick your boxes. So obviously, you know, 1, 2, 3, 4, and 5 can be very difficult. 5's at worst, they won't get up. It's a euthanasia. 4s, you're really starting to struggle. You'll see those horses, they walk like they're drunk. They don't know where everything is. 3s, you can see it, it's pretty obvious. Twos, you're starting to see the issues at walk. Ones can be a little bit question mark. They can be really hard ones. They're such a subjective thing. So how do we diagnose it? X-rays are not super sensitive unless you've got an obvious jump. So what we're looking at here is this is the canal where the spinal cord's running through. There will be narrowing through here. Usually it's at this area, somewhere along here, or there might be some up there as well from new bone growth. But you will get some compression down here. So how do you diagnose it definitively? We do a myelogram. Now, what is a myelogram? Myelogram is when we have to anesthetize the horse and then inject radiopaque dye into the CSF, into the spinal column, and we let it run down and we see where it's blocking and where it's not flowing. There's not equal. There should be an equal amount top, bottom, and it should just be uniform all the way down. So I don't know if you can see, it's not a great image. We don't do this procedure obviously in the field. It's a bit hard to get images, but you can see here we've got the white going down, up and down, and that's all fine. So why don't we do it more often? Well, here's one case. You can see this is probably a bit better. You've got the normal pattern through here, and then you've got loss of the radiopaque there and there. That's the big compression areas. So this horse is obviously a wobbler, and that's where it's been affected. One thing I didn't put in this report talk, I'm sorry about this, so I'll try and explain it. So why is the back legs affected more than the front legs? If we take a slice through the spinal column, and we think it's like that there, the tract for the front legs is actually more closer to the middle, and the tract to the hind legs is actually on the outside closer to the bone. So as a result, the hind legs are affected before the front legs. So you'll often see horses that are funny behind and they're not, and it's in the neck. Some people I've diagnosed and say, well, why is it the back legs? It's because of that fact. Is the anatomy, is the tract for the back legs is more superficial and closer to the bone. And so as a result, when you get compression on the spinal cord, that's the ones that get affected first. Even though it's in the neck, long way away from the back end, that's where you're getting it. The issue with the myelogram is not a lot. The studies suggest that somewhere in the region of 20% of horses won't stand after having a myelogram done to them. So why, we're not really sure, but going into the CSF, it obviously changes pressure and some horses won't be able to stand. So it really is something we do as a last ditch effort if we're trying to get a diagnosis. Treatment. There is some surgical cases have been done. It's a basket surgery where you basically fuse two vertebrae and you take out the compression. It was in favor for a while. It's lost of favor now. It's really not something. It's more a salvage procedure you might consider for a stallion or something like that there. But you can, if it's a young horse, if you've got a young warm blood that's maybe a yearling starting to show signs, really slowing down that growth can be helpful. We see it in thoroughbreds at times when they're being prepped for yearling sales. Just slow them down. Don't let them grow so big. They do quite well. So. Neck arthritis. Now, this might be more common than we probably realize. And it's something that you guys maybe will come across more than wobblers, because neck arthritis, we're saying more and more. Whether it's we're asking more of horses, not really sure, but it is definitely a diagnosis we're saying. And they can have interesting presentations. Can be stiff to bend one way, they don't want to stretch something, or they don't want to pull something. They can actually have mild neurologic signs as well, so they can be slightly neurological. Start to hang on one rein. Sometimes they can present with an abnormal lameness you can't block out, so sometimes neck pain has caused a forelimb lameness. Not all the time, but diagnosis by exclusion again. But yeah, it's definitely a possibility. And then also the horse will be unwilling to go in certain head positions. So some horses, you want to ride them up as a dressage horse and get them to sit up and sit. They'll really struggle with it and they'll just get a bit, and often I often see these horses that just look a bit, oh, that's a bit tight and that's a bit sore. And they'll start to get a bit of a head tilt and stuff like that there, we see. So you've got clinical findings, stiffness, mild neurologic. You can see this is a horse that's had a history of pulling back at some point, a young horse, and it's got, you know, new bone formation in the top there. Diagnoses, x-rays are useful. Ultrasound's also useful. Scintigraphy is still the gold standard. And the reason for that is because it shows activity. There's a study I'll talk about later where they've looked at show jumpers at a show jumping competition in America. They x-rayed all the necks and they found a high number of horses had signs of neck arthritis. Now, just because it's there doesn't mean it's a problem. So this horse here has got new bone growth on this joint here. It's got neck arthritis. We actually medicated this horse and it did improve with medication in this region. So we injected that joint with cortisone. But scintigraphy is still the gold standard. I don't like using the word gold standard, but it really does tell us the most things that are going on. So that's the one we go to. So what treatment options have we got? Like anything, it's no different to any other joint. So you consider, maybe for younger horses starting to present with, you consider your pentazans and stuff like that there. I don't think HA is really going to probably cut the mustard for these ones, probably more pentazan. And you can see here, we've got a needle going into the joint. We're injecting corticosteroids in there. Do really well. The only thing I'd be aware of is let your vet know when you're competing, because we need a long withholding period for whatever drugs we use in this region. So depending on the drug used, we're recommending anywhere from 14 to 21, maybe 28 days for some of the things. And that's because there's a high potential of leakage and getting into a ligament, and then it hangs around and it's going to leach out into the system and give you a positive result. So word of warning, just tell us when you're going to compete so we can tailor the medication to suit. But they do really, really well. I'm quite surprised, and often get a very long duration of action, a lot longer than fetlocks and coffin joints and hocks, to be honest. They really do seem to respond quite well. I'll just touch on a couple of, well, I touched on this one at the bottom, the radiological prevalence of osteoarthritis. It's quite a common presentation. The other thing I wanted to touch on is the congenital malformation that Sharon May Davis has presented. I think we need to learn a little bit more on this. That's my personal, because there's another paper that shows the presence of it without any clinical symptoms. So I think it's something, watch this space. I don't think it's the be all and end all, but there's definitely something there that we need to understand. It might be normal variation. So before we move on to kissing spines, are there any questions? Don't be shy, you can ask questions. Only I can see them, so it's all right, and you can ask them anonymously. So move on to kissing spines. So what is kissing spines? Do we need to be worried about it? So some interesting facts about kissing spinous lesions. Generally presents in the 5 to 8 year old range category. Unwillingness to go forward, poor mobility of back, lack of muscle development, very girthy, and pain on palpation of the back. So you've got kissing spines. How do we diagnose it? X-rays? Great, simple. There's a case here. You know, we've got two vertebrae very close together. We've got bony changes here. There's obviously something occurring. We've got sclerosis here, this whitening, some changes along the edge. Mild kissing spines, okay? Scintigraphy, come back to it, great. Picked up some activity that is at that specific horse. So, but I want to go through a little quiz with you guys. So this is just you have to interact, please interact. So I'm going to present 3 horses. I'm going to present their back x-rays for you. and I want some answers of which horse belongs to which set of x-rays. So I've got 3 different types of horse. I've got a 12-year-old 5-star eventer, was 4-star, but we'll call it 5 now. Competed for 8 solid season, competition record for every season, never had an issue. Only reason was x-rayed on its back was because it was being sold. Okay. Second horse, 15-year-old Prix St. George Inter 1 horse, solid competition history, regular history of competing. It is something I'll just raise. You're buying an older horse, do go back and look at its competition history. Try and see if there's any gaps. Why was there a gap? Is there a change of rider? Obviously, we buy a new horse, you want to spend some time getting to know it. You may, compete at HC if you're eventers, or you might change it. So there will be variations, but always look at it. But the 15-year-old Prix St. George horse was being sold as a young rider horse, signed at the trot, no pain on back palpation, moved beautifully, but the box was ticked for back x-rays. And then the third case was a clinical presentation of a 6-year-old show jumper presented for not wanting to jump. Didn't bend well from moving and had its performance was tapering off. So it was a nice 4-year-old, 5-year-old, 6-year-old not really reaching potential. And so we presented these 3. So X-ray A. So what can we see here? Bony change, remodeling, that's sclerotic lines. That means the bone's hardening. We've got an overlap here. We've got some changes here. So X-ray A. X-ray B. Pretty good spacing here. Good spacing here. A little bit of change there. Not much there. Looks pretty good. C. We've got 2 spots. We've got changes. Okay. Clinically, yep, not much there. So I'm going to launch a poll. So I'm going to give you guys a couple of minutes to answer the poll. So which set of x-rays belongs to the 5-star eventer? X-ray A, X-ray B, or X-ray C? Can everyone see the polls? Well done, guys. Keep voting. So, I think most people have voted, have we? Yeah. Okay. Now, someone's changing their votes. A couple more to go. There's no right or wrong answer here. Almost I can't see how you voted. So, okay, so 93% of you voted. Great. So I'll just run through what you guys have thought, and it's really fascinating. So, your 5-star eventer, 20% of you have said X-ray A, 50% X-ray B, and 30% X-ray C. So, would you be surprised if I said that's the 5-star eventer? That is the 5-star eventer. Never had any clinical pain, exceptionally well muscled, and no problem. Only found because it was being vetted for sale. Okay? So, X-ray C is actually your dressage horse. Is your Prix St. George Inter 1 dressage horse. So, yeah, That's his X-ray. Never had a problem. And then, oh, sorry, X-ray B, or X-ray B actually belongs to the show jumper. Okay, so why I did this is purely to show you what the issue comes with X-rays alone. Okay, I get people ring me or talk to me or send me a shot of X-rays, and I say it on Facebook, and don't join the group Horses with Kissing Spines. But anyway, you have to be very careful interpreting these X-rays, because all these horses, you know, we're looking at, that's the dressage horse. Okay, like it's a nice image. You can put it up and you could say that's, you know, Kissing Spines, and I can use that on Facebook every day of the week. But it's not clinically relevant for the horse. So that's just the take home I really want to stress to people. It's the one area of a horse when I X-ray from pre-purchase, I pray I don't see anything, because it's so hard to interpret these as a baseline on your X-rays alone. Trying to baseline assess these is just is troublesome, and it just opens a whole hodgepodge. To the extent that the European Equine Veterinary Association have actually put out a memorandum or whatever saying they advise against X-raying the back. I think it's a hard one, because I think you got to assess the whole picture, and it does affect your risk category. It does assess your risk category. You know, if you see it there, you've got to assess it, but how clinically relevant it is, what you plan to do with the horse. So it just creates a whole can of worms that we're really not very hard to give you guys honest appraisal. Okay, so someone's asked a really, really great question. What's the normal incidence of kissing spines on X-ray in a clinically normal horse? It's a hard one to know, but I know for a while there, a couple of years ago, it became quite an in vogue diagnosis. So I went through a period of X-raying a lot of horses when I was X-raying for other things, just out of interest sake. I think that it's quite a low relevance, but we do see it in older, you know, sometimes you see it in older horses, but it's irrelevant. So there's, I would say 20 to 30% of horses will show some radiographic changes that you could convince yourself are part of a kissing spine issue, but I'm just not sure that they're really relevant. So it goes back to trying to find whether they're actually a problem. So how do you find there's a problem? There's a couple of ways to do it. One, scintigraphy, obviously. Great. Pick it up, see if it's relevant. If you don't want to go to scintigraphy, we can actually do nerve blocks. We can put local anesthetic around those areas. Got to use X-ray guidance to make sure we're getting the right spots. X-ray, block them, see how the horse does it, change the horse's gait and the way of going, and that can be a useful, relatively simple, bit time-consuming way to work out is that a problem or not. So good useful tool. So how do we treat it? Rehab. So when I go back to when I talk about muscles are so important. The X-ray I showed you with the eventer, he had the most beautiful back muscles. You could palpate him, you could move him up and down. He probably didn't move as much as you would have expected, but he moved and he was not uncomfortable doing it. So he obviously couldn't move as much because he has got some bony issues, but he had beautiful back muscles. That horse was sold, and I followed up the purchasers, and he's never had any back problem. They went ahead with it. So rehab, you're building up the back muscles. If you've got a horse that's weak in its back, you've really got to build up those muscles. The injections, it's cortisone. We sometimes use drugs called osphos and Tildren. They're very common. So they're just to stop the bony remodeling. Shockwave therapy can be very beneficial for management. And then surgery. Okay, surgery is, people talk about it. There's two types of surgeries. There's the ligaments cutting. So they cut the ligaments between the spinous processes, and then you can do you shave the bone. You cut off bits of bone to give more space. Basically, you're doing a neurectomy of the back. That's the simple terms. You're cutting the nerves, you know, and then you're working on the rehab. So I think it's something you have to be aware of. No one really talks about it, but you are cutting the nerves. Maybe I'm negative because I'm not a surgeon, but I haven't sent many horses. I think a lot of horses can be managed and treated with these other things before we get to surgery. But it is a time-consuming process. So we've got to build the muscles up again. You as an owner are so important. You've got to build up the strength along the back. It's daily exercises, quality, not quantity. And then you build up all the strength. So you want to build up the strength in this region here. Often I keep you guys off as a rider, and we'll use a lot of lunging. Quite like these systems, the equiband system, you're trying to encourage the horse to work from behind and lift, and lifting on the core. There's a band that can go underneath here that it can lift them. Do word of warning, if you're planning to go and purchase one of these systems, do check your horse likes it before you purchase it. I've had a couple of horses go into bucking fits with this strap. It has to be tight, not too tight, and vice versa, because they can go into a bucking strap. And even this here, if it's loose and ends up back here, you can end up as a bucking strap and end up in all sorts of world troubles. So your pole work, this is obviously a very extreme example. Beautiful horse moving over these, stepping over the caballettis, all those things that we talk about, backs and stuff like that, really beneficial. So we talked about the cortisone. PRP is another thing we've sometimes injected. So some horses that are prone to laminitis, I'll use PRP. That seems to work really well, helps repair and takes the inflammation out of it, and the shockwave therapy. So take home for this is the presence of does not equal disease. Please remember that. Understand at pre-purchase time, you're buying a horse, you're spending your money. No different. Went through the purchase of a horse recently. I x-rayed the back. I did. You know, I prayed I saw nothing, but because it just makes my life a lot easier, because it's so hard to give an interpretation of what you're doing. But treatment's really built around, but you just, I know we all want to know if it's there or not. So you will x-ray it, but and pray it's not there. But if there's no changes on x-ray, you're pretty comfortable. If there are changes on x-ray, then you open the can of worms. When you talk about treatment, it's the muscles. We need to get those muscles back. So we need to get your muscles moving and develop them and get the horse comfortable again before you start putting a rider and saddle back on board. So any questions? No. Okay, so sacroiliac joint disease. I think I see three distinct categories of SI joint pain. So SI joint pain, you know, you can palpate it. They're a bit sore over the rump, you know, just behind the saddle, running into just the side of the pelvis. I see three conditions. You got SI joint dysfunction, genuine SI joint injury, and then secondary SI joint pain. So when I say dysfunction, I see this condition in young warm blood, so 4, 5, 6-year-olds, where they really, for some reason, struggle to sit. You palpate, they're sore through the SI joint region, and those horses often respond really well to treatment, and then I never see them again. They just, it's not that they disappear, they're still in the system, they're still part of the practice, but they just seem to respond, they get over it. It's almost like a young horse dysfunction, and once they get that moving and getting that strength through that region, they can pass on and they go fine. You got your genuine SI joint laying with it, really sort of palpate. Those are the ones. And then you get your secondary SI joint pain. So hocks and SI joint pain seem to go very much hand in hand, or proximal suspensory, hind limb proximal suspensory and SI joint pain can get that there. They seem to present very similarly. These are sort of some of the symptoms. Disuniting in canter, I see quite commonly as a big problem. Pain on palpation, don't want to sit. And also loss of muscle over the SI joint region. Come back to, if you don't use it, you lose it. And then the hunter's bump as well. Diagnosis can be hard. So the clinical signs is often one way. Scintigraphy, great, very sensitive, can pick up the hot spots. Or often I'll do a treatment trial. And by that I mean I will inject and medicate the region and see what gauge the response is to that there. So with the treatment, the one thing I'd say is I tend not to rest them unless they're genuinely painful. So the dysfunction horses, I wouldn't be resting for too long. The secondary SI joint pain, I wouldn't be resting for too long. The ones that are genuine lameness caused by SI joint, sometimes I will rest them for a period of time, but I want to get them back into some sort of rehab work to try and build up the strength so that they're very strong through that region. And it again comes back to the muscles. So treatment options I've got in my repertoire are shockwave therapy, and can be beneficial, but getting the penetration depth right to the bottom can be hard. And then injections, some sort of medical therapy. When we're injecting SI joints, it can be, this is something, we use ultrasound guidance. So pelvis, transverse process of the lumbar vertebra, and we always use the ultrasound. We're trying to get the needle into here. So you'll see it just appear in a second, coming in here. We drive this needle deep down in. Now, it looks very simple on this screen. It's anyone that's seen me do it, we use a 10-inch long needle to inject in there, and we need every little bit of it to get in. So for a big warm blood, we're looking 10 inches. Thoroughbred, you might get away with 8, but we're driving the needle in underneath the pelvis, deep down in, and using some sort of anti-inflammatory therapy. So 2 options for them. Well, 3, I split into 2 categories. You've got your cortisones, and then you've got your biologics. So cortisone, we'll be using a longer acting cortisone. Be aware the swab time can be a bit long. And then the biologics, maybe something like PRP or even IRAP as well. I have used IRAP in one case. It seemed to respond okay. But they're definitely a very useful therapy. I find injection probably the best way. My go-to management for these, because I think they just respond better than the shockwave. And it just, shockwave's 3 treatments, a fortnight apart, so that's also a month, whereas cortisone, when we medicate them with cortisone, I say anywhere from 7 to 21 days for an effect, clinical effect. So, I've got a question. Someone's asked, does the injection have to be done under ultrasound? Yes, it does. You just, I do them often enough. I'd probably say I do one once a week, twice a week, maybe. I do 2 horses a week. And I'm amazed the number of times that I just don't get it in there. I just don't, even though I've done it plenty of times and should be able to do it blindfolded. Different horses, now even when a horse moves and say rests another leg and tips the pelvis, you'll end up with the needle. The best way to describe it, this is my ultrasound probe here, so I'm on the edge of the pelvis here. I'm starting back here to inject. So give that, the width of my computer, I'm starting back here and I'm injecting down in. So I would use ultrasound all the time to inject those. So yeah, ultrasound all the time to inject them, have to. Traumatic back injuries, most common in young horses. The flip over events, so the pullback. Obviously I showed you this one before, pullback. And then this is one, fractured withers. This horse flipped over in the wash bay and fractured its withers. Unfortunately, this horse was actually an older horse and got a fright and slipped and landed on his withers and crushed them all down. So you can see here they're overlapping. Obviously, one of the issues with X-ray in this area is you can only do from the side, you can't do from the top. So we can't see where they are in position to each other, but you can see they're crushed down. And the horse's wither was squeezed right down. So a bit sad. This is a pelvis fracture. Highlights the benefit of ultrasound. Ultrasound doesn't go through bone. You've got that there, beautiful normal pelvis, we got a break here. You know, we've got a little fracture. So horse did really well. So last topic, I've touched on it already. With regards to pre-purchase and backs and necks, it's a really difficult one, and it really comes down to a personal choice. I think if a horse has got a limited movement of its back on clinical exam on pre-purchase, then yes, I'd recommend x-raying at pre-purchase time. If the horse is good, where do you draw the line of what you're going to x-ray? If you're doing other x-rays, it probably doesn't cost a whole lot more to do the back. You might do it, but then you might walk away from a horse that turns out to be the 5-star eventer that goes on, you know, for years. We don't know, because we're not lucky to have horses, you know, to x-ray all, you know, 2-year-olds and 3-year-olds have started and follow them through. That's one of the big things in the performance horse world we're really lacking, is long-term longitudinal studies to assess these horses over time. You know, where does horse A go to horse B? And equally, you know, and I can understand the economics of it, as say you guys are all here and you've got young horses, 2-3-year-olds, and you break them in, get them going, and say, oh, we'll x-ray them, we'll put them as part of a study, we follow them through. Well, you might have sold a horse. You're not probably going to want me to ring up the purchase and say, oh, by the way, we knew something on those back x-rays, can we just follow it up? That's not going to work. So we really struggle to follow these up. I'm torn, really, to be honest. I did it myself. I did x-ray the back, but it is an area that I pray I don't have a problem. I really do pray I don't have a problem, because it's just a big can of worms how to assess it. And it just comes down to personal choice, really. It's a really difficult one, really, really difficult one, because I think you could end up walking away from a good horse that doesn't have a problem, but equally you could be buying a horse that does have a problem and develops on. But I think maybe a take home is, if the horse has been done it, shown it, proven it, maybe x-raying an older horse is of limited benefit. But if you're looking at a younger horse or hasn't done much work, you maybe want to pick it up. As the studies will all show, we identify that they generally present in that sort of 5, 6, 7, 8-year-old age category. So you want to follow it up. So final slide, the back is the drive shaft of the engine and needs to be treated that way. So we really do need to follow it through and really invest in looking after horses' backs. So I hope you've enjoyed. I've just got one, someone's just asked a question. How relevant is pain on central spinal palpation with kissing spines? Well, I think you've got to, it's relevant, but you've got to understand we've got so much muscle as well. You can have muscular or ligament pain. Ultrasound can be useful for those, assessing them. So I think the take home is, good question, how relevant is pain on central spinal palpation with kissing spine? Got to be interpreted as part of the complete picture. I don't think it's the be all and end all. I've seen plenty of horses come to me because they've been thought to have kissing spines, so they're, you know, pain on palpation, and we've x-rayed and we can't find anything. It's purely muscular. There's all sorts of reasons for muscular pain, but so I think it's part of the equation, but it's not the be all and end all. So, no more questions. Thank you very much for attending. There'll be, in a couple of days' time, we'll be sending out the link for the video. There's a short survey just at the end of this. I'd really appreciate your feedback if you could just fill it in for me. But once again, thank you very, very much for coming. And yeah, we look forward to having you at the next one. And if I can be... And sorry, come back. If I can be of any help, or you have any suggestions for another webinar, I'm happy to take suggestions. Please send them through. And yeah, thank you very much again. And I do appreciate it. Thank you very much.